Assalamu alaikum and good afternoon. Thank you, Mr. Chairman. I have been asked by the organization committee to present a case about ventricular arrhythmias in patients who underwent revascularization and their ejection fraction is more than 40%. So this is my case. The story with this patient started in 2009. He was a 42-year-old gentleman who presented to Prince Sultan Cardiac Center in Riyadh with atypical chest pain and class 2 shortness of breath. His cardiovascular risk factors include type 2 diabetes mellitus for more than 3 years and systemic hypertension. His baseline echo demonstrated low normal ejection fraction around 50 to 55%. He also had grade 1 diastolic dysfunction and mild mitral regurgitation. Otherwise, the echocardiography was normal. The patient was decided to undergo coronary angiogram, and it was done, which demonstrated a tight lesion at the proximal LAD. The circ was free of significant disease, and his right coronary system was non-dominant. The RCA was non-dominant, and it has two large RV branches, two marginal branches. The first is smaller than the second one. But as we mentioned, it is a non-dominant RCA. So this is another view of his RCA, just to remember it. The patient underwent stent to the tight lesion in the LAD area with good result. And after the procedure, the patient stayed for 1 or 2 days in the hospital, and he was doing fine, and he was discharged home on aspirin, Plavix, statins, ACE inhibitor, beta blocker. He came to the OBD in a regular basis, and during this visit, patient was completely asymptomatic. About 2 months ago, actually less than 2 months ago, the patient presented to our emergency room with 3 hours history of chest pain. His physical examination at presentation was basically unremarkable, and ECG was obtained. Any comment from the audience? So basically, the ECG demonstrated that there is ST elevation in V1, V2, and V3. So the on-call at that time decided to take the patient immediately to coronary angiogram. The cath lab was activated. Few minutes later, after this ECG, patient had initially monomorphic VT according to the ER doctor. In the monitor, there was a monomorphic VT, which degenerated into polymorphic and subsequently VF. The patient arrested, cardiopulmonary resuscitation was started, and DC shock was delivered successfully. The patient was quickly moved into a stretcher, and the way to the cath lab, there is an elevator in our hospital. In order to go to the cath lab, you have to take an elevator, which is not a good idea. Once the patient entered the elevator, he had another episode of VF and required another DC shock. Patient again rushed to the cath lab. On arrival to the cath lab, before he goes to the table, he had a third episode of VF arrest, and he received a third shock. Patient was moved in the table. Again, in the table, he had a fourth episode of VF arrest and a fourth shock, and he continued to have non-sustained episode of polymorphic VT. The puncture was done quickly, and people, the on-call team was anticipating that the patient probably has stenosis into probably proximal to the stent, because the changes were in V1, V2, and V3. They were ready with a wire. However, the angiogram showed patent left main, patent proximal LAD, and the LAD stent and the LAD itself were free of significant disease. Also, the circ was free of disease. They went to the right side, and they found that the non-dominant small RCA is now totally occluded, and it is the cause, it's most likely cause of this recurrent VT-VF. In our practice, we see our colleagues, they usually underestimate the non-dominant RCA. And in an elective situation, people might not consider doing a PCI to such vessel. However, as we see, this small non-dominant RCA was a cause of significant arrhythmia. The wire was passed, and once the wire passed through the vessel, the arrhythmia settled down and patient stabilized. Stent was deployed with a good final result. Now you can see the marginal branches are back, and patient left the cath lab in a stable condition. His post-procedure angiogram demonstrated widespread T-wave inversion, and the ST elevation had subsided. The next day ECG again showed that ST segment is almost disappeared and the T-wave inversion had improved. Echocardiogram was done, which again showed that actually the ejection fraction had improved. Now, his ejection fraction is almost normal, 55%. So what do we know about arrhythmia associated with acute coronary syndrome? The most large experience with the incidence of arrhythmia in patients with acute coronary syndrome comes from the GUST-1 trial. The GUST-1 trial, as you know, had more than 40,000 patients with ST elevation MI in the thrombolytic era. The overall incidence of sustained VT or VF was about 10.2%, which is high. And in addition to that, people who had arrested before the hospital are probably not account for in this percentage. The percentage of VT was 3.5, 4.1% had a VF, 2.7 of the patient had VT and VF. Almost the majority of these arrhythmia occurs in the first 48 hours. And we learned from that trials that patients with arrhythmia, primary VF, in the acute setting, within 48 hours of acute coronary syndrome, their long-term survival is not affected. However, their short-term, their in-hospital mortality rate is significantly increased if they have VT or VF arrhythmia. Therefore, most of the guidelines suggest that these type of patients with VT, VF within 48 hours, they don't require long-term ICD implantation. Why ischemia happens in such patients? This is multifactorial. You know, during acute coronary syndrome, you have autonomic changes, you have acute strain of the LV muscle, which promote arrhythmia. In addition, ischemia itself leads to cellular necrosis and formation of substrate within the myocardial cell for arrhythmia. In addition, the patient might have a pre-existing disease, a pre-existing arrhythmogenic substrate like prior myocardial infarction or DCM or ARVC or long QT, which may increase his incidence of having arrhythmia during an acute coronary syndrome. What is unique about this patient that he had a significant arrhythmia, VF arrest, incessant, due to small vessel occlusion, which is the non-dominant RCA. When I looked at the literature, there is few case report about that, about 3 of them, that they had reported such arrhythmias, incessant arrhythmia, in case of non-dominant RCA occlusion. Why does that happen? There is a lot of theories. We know the RVOT is of a special interest to the electrophysiologist, as you say from Dr. Hassaniya, patient who had ARVC and history of had a BVC from the RVOT and history of sudden cardiac death in his family. The RVOT is associated with idiopathic VT, is associated with some malignant form of BVCs, and also it is related to the Brugada syndrome. The pathophysiology of Brugada syndrome is related to the RVOT. And actually, I found this case report recent this year, about 2 months ago, that you could, if you have ischemia to the RVOT, you might have the same ECG changes as Brugada. Whether this ECG changes are associated with increased incidence of arrhythmia, especially during the ischemia, this is largely unknown. I thought this case was interesting and it would stimulate some discussion today. Thank you very much.